Sorry about the technical difficulties. Oh.
He's been going.
Is he been going?
Yeah.
He's going to find yoga. Chapman, I mean,
Yeah,
wow.
I'll go when the ladies come back. Oh, that's stupid. That's an amateur move.
You're live, Dr. Chapman.
Well, good morning. My name is Jens Chapman, and I welcome you on March 3rd, 2021 from the Seattle Science Foundation and the SSF-TV program. Today is a STED talk, a spine technology, education, discovery, discussion, and discourse. And it's a special honor to have you here. The theme today will be healing, and obviously not just in a holistic sense, but as the day emerges and the session will emerge, I think you'll agree that there's an almost holistic approach necessary to achieve what we're really going to talk about, which is bone healing. All of us are taught that there are 4 phases of bone healing, and this will be substance of the discussion later in our guest presentation. I'll introduce a guest speaker later. But between hematoma formation, the initial callus formation, the callus maturing, and then remodeling, this is an arduous and somewhat really fragile act, this bone healing. So we'll talk about healing in terms of bone healing today. And there are 2 types of human beings. Good morning. There are the healing, the bone-forming people and non-bone forming people. Just before we go on with the introduction of the theme today of bone healing, I want to reflect back on last Saturday's outstanding 7th annual lateral access course. We're slowly to start opening up again. We had a very nice attendance. We had about 20 to 30 attendees live here, all distanced with masks. And we had well over 400 people follow the day-long course that Dr. Oskuyan started 7 years ago. And on that left top slide, you see the 3 pioneers of this technique. Dr. Pimenta on the lectern, Dr. Juan Ribe, now from Arizona, and Dr. Oskuyan. And it's really amazing who all came together. And it was a who's who of the far lateral access world. And the exciting things happen here. You can see on the top right, a new form of a prone position, simultaneous access technology with a self-retaining retractor system that's integrated with a table that really secures a patient. This is a cadaver, just so you're not totally shocked. And again, we had on the bottom left, you see a fellow who's never done it, and he's basically on this cadaver, who's successfully using this technology for docking. On the bottom right, you see Dr. Pimenta, who on Friday night gave our fellows and attendings a personal demonstration of how it's done. So new things are happening and life goes on past the virus. And congratulations to Dr. Oskuyan and his co-chairs for a fabulous meeting.
So Jens, I just have a quick comment. I really appreciate you putting this up. So what's remarkable is this same group, what we always joke is Luis had the idea, Juan took the credit, and I did the cases. Where, you know, this same exact group, it was just like Friday night. You know, myself, I mean, people thought we were crazy, and it actually all started in Seattle. Luis has a great story about it, and it was at a AANS meeting. So it was great to get the old gang back together again.
So thanks for that commentary, and again, congratulations on having had the idea, and this group of 3 great surgeons was live together again. Was really a very special occasion to see. And again, I think that this is a great example of how we can improve our healing by being less traumatic to tissues. And I'm excited that we can now look at possibly being even more efficient and less invasive for our patients in the future. To be continued, but back to bone healing, which we're going to talk about. Why can it be so hard? So rough time outline, 6:30 to 7:30, we'll have some cases. We have 3 of our great fellows presenting 3 cases, all with bone healing problems, and they come from the recent past. We're not going to mention the dates exactly because we don't want to identify them. And again, we're going to then have a guest lecture at around 7:30 to 8 o'clock, but maybe you'll start a little bit earlier. A typical STED type talk, 20 minutes plus 10 minutes discussion on what really matters for bone healing and what's out there. And going back to this fragile undertaking before our first fellow, Dr. Elias will take the helm here. These are just a couple of things that I could, at moment's notice, think about that influence bone healing. So as you're seeing these cases, you can literally go through a checklist of what is going on with these patients and where what may have failed. Vasculature, stability, biomechanics in terms of the alignment of the structure, in our case, the spine, but it goes for limbs just as well. The actual bone substance, is it osteoporotic or is it a completely burned out sclerotic bone? The electrical charge, believe it or not, Ravi, did you know our bone is electrically charged? Our bones are smart. Who knows what they communicate with? Who has a microphone? Dr. Gayumi, do you know what they communicate with? What do bone cells communicate through? Canaliculi. That's a cavity. Calcium channels. They actually talk to one another with calcium channels. The signaling is calcium channels. You have a lot to do, doctor. This is not oral boards. We're not supposed to do oral boards here, but calcium channels are the messengers. Electrical charge. Now you know Ravi. Ravi's just happy. For those who can't see it, he's happy that Dr. Gayumi got called out. Obviously, we need a healthy soft tissue coverage. If it's just scar, it's not going to help, and vasculature gets affected badly. Sterility, we can't have a crassly infected environment and expect that to heal. Hormonal status, we do need a very careful hormonal balance. I'm not going to ask right now because we're going to go there later with our guest speaker. And we need a healthy nutritional state also. These are just a couple of things that as we look at the first cases to come in, and again, our patients challenge us in unprecedented fashions. And I mean, these are just some generalized pictures in terms of how challenging it can be to kind of do things. And again, one of the biggest evils for us, and Dr. Nuna is actually, maybe you can make a small reference to that later when you present your case as number 2, how bad smoking actually is. He actually revisited this age-old topic and did a really deep dive. And I think it's actually far worse than what we thought. We thought it's just okay to stop smoking, and then the next day you can do surgery and maybe have good bone healing. And maybe Dr. Nuna can just make an extempore statement about that. And so nicotine is a bad thing, and obviously weight and biomechanics and nutrition are challenged with our general BMI problem. So 3 spine fellows will present 3 cases, and this is again our STED talk. So Elias, take the helm.
So good morning. Thank you, Dr. Chapman, for the introduction. Okay. So my name is Elias. I'm one of the spine surgeons here at Swedish. I will present this case. I did it with Dr. Oskoyan last week. So this is a 63 female. She had already C2 to T2 posterior cervical fusion 2 years prior to presentation. She presented with, so few months after the first surgery, the patient started reporting neck pain. She had a cracking sound in her neck, burning sensation over the suboccipital area. And this burning sensation progressed to burning sensation over the bilateral upper extremities. So her pain was becoming more and more severe, and it was affecting her quality of life. It was limiting her range of motion, the neck, her cervical range of motion, and the pain was also inhibiting her ability to engage in routine daily activities. And so over the few months after the surgery, the patient started having difficulty straightening her head up. So whenever she stood straight, she started feeling pain and shoulder fatigue. She didn't report any bowel or bladder problems. So on physical exam, she had tenderness, mainly she had tenderness over her upper cervical area. Hoffman was positive bilateral. Her normal posture is chin to chest position, and motor power was 5/5 all over. So, Dr. Chapman, do you have any questions before I go to the imagings?
Can't wait to see the imaging. Thank you.
Okay, so the patient presented to our clinics and we ordered an X-ray first, and this was her first imaging. So as you can see here, this is the C2 screws, and those are the T2 screws. And do you want us to comment, Dr. Chapman, or should I go and comment?
No, I want to ask questions.
Okay.
So thinking back, so this patient was treated in California, is that right?
Uh-huh.
Yeah. What was the reason for the surgery? What was the indication as far as you could reconstruct?
Multiple degenerative disease.
When you have a patient coming in,
Yeah.
just first time, thinking about what I just said in terms of bone healing, what are some of the classic questions that you just kind of kindly fire at them or that you go through in your mental checklist?
Okay, so first I would ask about steroids intake.
Why steroids? What happens with steroids? What do they do that is harming to bone healing?
It will cause osteoporosis, and it will prevent bone healing later on and bone effusion.
So I showed those 4 phases of bone healing. Sorry, I'm putting you on the spot here.
Sure.
Which phase does it interfere with? 1, 2, 3, 4.
Is it the fourth?
First was the hematoma.
No.
Second was the kind of the initial rough cartilage callus formation. Third was initial bone maturation, meaning mineralization. Fourth is remodeling. Which of those 4 phases gets interfered with?
I think it's either 3 or 4.
Wrong.
Okay.
2.
I didn't
The
know
inflammation, that initial congealment of cartilage and everything is an inflammatory act.
Okay.
This is why in our checklist, we don't just ask for steroids, which you correctly pointed out. We also ask for anti-inflammatories.
True.
And we want to stop those.
Yeah.
Because between phase 1 and 2 is that inflammation. This is why fractures or injuries turn red and swollen. It's inflammation.
Okay.
The signaling from the cytokines and the bradykinines attracts the healing response.
Okay.
So at least for 3 weeks, you don't want to have that anti-inflammatory effect. So steroids?
So no steroids, no anti-inflammatory, no smoking, as we said, good nutritional balance, and no cachectic status. What else?
Yeah, those are some of the main factors.
Yeah.
Obviously, tumor care.
Yeah.
Now, when I see this kind of a construct, and obviously you cut off the soft tissues a little bit, I have learned the hard way that posterior soft tissue coverage in these larger cervical thoracic surgeries is actually a really big deal.
Yeah.
So what could be the problem in a patient who had a very long cervical thoracic fusion done in terms of the soft tissues? Why is this a worry?
For wound healing, you mean? And
Dehiscence.
yeah, so to prevent dehiscence later on.
And where does the main dehiscence take place in a patient like this? If you can point to that with the arrow, it's right down here.
Yeah, it's
why
over
is that? What happens?
It's over the cervical thoracic area.
What is that called? That dehiscence has a name.
Yeah, it's a trapezius.
The patients present with a so-called delta sign. So the trapezius wings, okay?
Yeah,
they have like wings.
Yeah.
And the trapezius splays, it's called trapezius splaying. So the shoulder muscle activation, these patients pulls apart the scar.
Exactly.
And they get these broad, and they get a lot of myofascial pain, more so than usual.
Yeah.
But what does that matter for bone healing? Why is this a problem for bone healing? Or can this be?
Is it because of constant inflammation? Or?
You lose your muscle coverage.
Yeah.
As I said earlier, you need to have a muscle bed for bone healing.
Okay.
Right? Okay.
Yeah.
Now, there's one other thing that I mentioned before that's really bad here. There are probably 2 other things as I'm looking at this.
So I think there are multiple factors in this lady, and one of them is the construct itself and the length of the screws, maybe. I mean, I will go over the CTs now. So this is her CT scan, and this is the CT scan pre-op. 1 second.
And how far was this patient out from surgery?
2 years.
When do we think this lodgement happened?
I think a few months after the first surgery, when she mentioned that her neck, she had a cracking in her neck, and she started feeling all those symptoms.
I have a stupid question. As I'm looking at those images, Where did the nut go from that connector? Oh, there's a nut. Okay, I somehow couldn't see the locking nuts. They're there. Okay, I was worried that they wouldn't be there. So what all has not healed now as you're looking at this?
So she didn't have a proper bone effusion, and there is lucency around the screws, as you can see over here, mainly over the C3 screw, and the rod has pulled out from the C2 screws, mainly the left C2 screw.
So what segments are healed, what are not healed? If you can go through it sagittal again, that's a very nice picture.
Yeah. So mainly the upper cervical didn't heal well.
C2-3, I agree.
C2,
and what about C3-4? Show the arrow at that joint.
1 second, I have to stop the.
Yeah.
So this is C3 here, and as you can notice, there is a radiolucency, and C3-4 is not fused also.
Okay.
So you can see the joint over here between C3 and 4, and as you can notice, it's not fused.
Okay.
And there is enterolesthesis of C2 over C3 also of 6 millimeter, which is causing canal stenosis.
So in the error analysis that I kind of gave a brief overview before, what do you think went wrong here?
I think it could be a surgical technique error or a surgical planning error.
Or what on the physiologic side may have gone wrong? So surgical technique, clearly a potential factor.
Yeah.
What patient risk factors apply?
So the osteoporosis could be a factor.
Osteoporosis, I buy that.
Yeah.
What else?
The patient is not a smoker.
So when I see this kind of an anterolesthesis,
Yeah.
there are two things that immediately come to my mind. First of all, I talked about biomechanics and alignment. Is this a good alignment? Is this good biomechanics?
So she, initially, I have excess scoliosis, but it's not here. She has a good balance, like a global sagittal balance. The patient,
That can't be. Her C1 is anterior to the C7 vertebral body. If I went back to Dr. Gayumi, who's doing a wonderful cervical spinal alignment project, that's far from normal. C2 is anterior to C7.
Yeah, so she has now the C2 anterior to C7.
Yeah.
Pre-op, this was not present.
Yeah. So, okay. So this was a failed deal. Then the second thing, when I see these kind of step ladder step offs, this is classic in the cervical spine for another condition. What is that? This is a guess what I'm thinking question. Inflammatory arthropathies. Does she have any rheumatoid arthritis, anything like that?
No, she doesn't have arthritis.
And she's not on anti-nuclear, anti-inflammatories, advanced anti-inflammatories, anything like that? No. Okay. So Rod, what do you think went wrong in her? You've taken care of this patient. You've seen her, obviously. What's her problem?
I mean, she had multiple surgeries. Unfortunately, I think she wasn't the best surgical candidate to begin with. You know, chronic pain, smoker, and just never healed and kept getting surgery after surgery after surgery after surgery. Finally, you know, she just kind of tipped over. I think she got myelopathic, and you know, she had her hardware pull out. And I think between just the construct and constellation of postoperative symptoms, she just never healed. And you can see Dr. Chapman's point about the muscle coverage. I mean, she had not excellent, you know, just because of her nutritional status and the multiple surgeries, just didn't do well. You can see all the fluid around the hardware. So
it looks very much like she has significant myopathy. If you look at those axial cuts, can you put your arrow on that? That's a really nice depiction of just very deficient muscle. She probably has trapezius dehiscence also back there. So when she stands up, you can probably palpate the posterior elements and the screw heads. And she's myelopathic now, so there's no question that you need to do something. So as we want to repair this, we obviously want to have maximum bone healing. So where's the main weight transmission take place, and what do we want to do for alignment correction to kind of get this forward slip out?
So obviously we need to take the patient for surgery again. and we need to correct it. So we did both anterior and posterior approach on her.
So anterior serves what two purposes?
In order to recorrect or to try to get the lordosis back for this patient and to correct the enterolesthesis.
So to correct the deformity part, the kyphosis and the enterolesthesis, and the second part is what?
For to give her a better fusion posterior.
Maximum fusion bed. You have the weight transmission.
Yeah.
Go back to that standing film.
This one.
Yeah, this is good enough. Yeah, this is better. Do you know what we call, where does the normal weight transmission go through in the cervical spine? Do you know where on the lateral you draw that? If you put the arrow on a certain spot, where is that? And I asked Dr. Gayumi to come up in a second and show us.
Is it, so it should be like the C2, C7?
No, but where in the vertebral body would you draw this? There's a name for it. I'm going to ask you for that also. Do you know where that center point is? The center of transmission?
I would go mid C7 maybe, or mid C2.
Yeah, no, we're not talking. Can you run up and show him where that is? I'm asking weird questions this morning. He's putting on his mask. Good man. And what is the proper name for this? And by the way, for those not in Seattle, it's a beautiful morning.
I'm assuming it's going to be in the.
It's in the posterior third of the vertebral body. So posterior third. So go up to like C5.
C5-ish, 2, 3, 4, 5.
That's facets. Posterior third. Posterior third. Posterior. There.
Right there.
And what is that called? That area?
I'm not sure where you're getting it.
Instant axis of rotation. That's the flexion, extension, rotation arc. It's in that posterior third of the vertebral body. So now you know.
Now I know.
Good. Thank you. Calcium, second learning point of the morning.
Perfect.
2 for 1. I will not tell Dr. Wong that you did not know how bone cells communicate. All right. So, Rod, what was your surgical plan then?
I mean, I think for me is getting, realigning your neck and getting this thing to fuse. So that was kind of our goal. As you pointed out, I mean, I think, going anterior, you get a lot more surface area, and then you get pretty good correction, and at least try to attempt to realign, decompress, and it'll give us a foundation to actually start getting her to fuse. So that's what we did.
This is always a big question for me. When I have patients with hardware, even if it's failed, should I take the hardware out first and release the spine posteriorly and then do the deformity correction anteriorly? In other words, what gave you the assurance that you could do this in 2 stages, meaning front and then back, and didn't have to do 3 stages?
Fortunately, we got a CT scan, and you could see the C2 screws had pulled out, and the C3 screws were out as well. So
like the posterior construct was already disconnected.
Yeah, it was all disconnected.
Yeah.
But that's a great question. If it wasn't, we'd go from the back, go back, front, back.
Release it.
Yeah.
All right.
So what we did, Dr. Chapman, was we did 2 levels ACDF anterior approach. As you can see here, we did C2, 3, C3, 4. And then we flipped the patient and we did the revision of the posterior construct. And we inserted longer screws. So this is the final post-op imaging.
Looks beautiful.
So we used the longer screws for C2, and for the lateral masses, the previous screws were 12 millimeter. We used 16 and 14. And we drilled all the joints, and we used BMP and bone graft.
I want to point out the BMP was used in an off-label fashion, of course, and we're not endorsing its use.
Yeah.
The C2 fixation is beautiful. Now, the previous screws, were they compromised or not?
They were not, but we wanted to make them longer and get a better purchase. I think they were 20 and
They were 20, yeah, and we used 28.
we
And,
used 28 millimeter.
All right, that's beautifully done. When you go to the upper cervical spine, do you go from the right or the left side usually?
You know, I don't have a preference because I'm right-handed. You know, I can do either side.
Yeah,
Yeah, I tend to go from the left.
Got it.
I don't think it matters.
How's she doing now?
She's doing great.
All right. So nice case, instructive. So for me, the learning points here, this is a biologically impaired patient. So on the
Yeah.
biologic side, we have several risk factors. She's a smoker. And our next speaker will be Ravi Nuna with a case, and he'll address the smoking issue quickly. So put some numbers to that. He doesn't have a slide for it, I think, but he'll give us some general outlines. The second thing is she looks pretty large and is probably malnourished. Did she have diabetes?
She doesn't have diabetes now.
She's had previous surgery with likely poor muscle coverage, or at least fascial dehiscence, and she's biomechanically in a very adverse environment.
Yeah.
These grafts that you put into the front, what are they? Do you know what they are? What material is that?
The bone graft, you mean?
Yeah, what is that from the patient? Where did that come from?
No, this is not from the patients.
This is, if it's not from the patient and it's bone graft, what do we call that in medical terms? What medical term do we use?
The autologous bone graft, you mean?
Huh?
The
We call that allograft.
yeah.
This is an allograft, okay? Now this looks kind of weird, this allograft. This has two different components to it. What are those? Do you know what that is?
No.
So this is a machined allograft. The front part is cortical bone from a femur, and the back part, this peg sticks into cancellous bone. So they actually machined this out of 3 pieces. You didn't know that, did you? The front part is a cortical bone. That's basically 2 pieces that are pressed together. And this is actually machined femur. The back part is a cancellous bone that's kind of machined and then stuck onto it. So this is, it's not glued, it's a press fit. Okay, but the idea behind that is that the front part basically maintains lordosis. The back part collapses into the, what's that biomechanical magic spot of the cervical spine called? The instant axis of rotation, okay? The posterior third of the vertebral body. And that cancellous bone is more conducive, ideally, towards bone healing.
Nice.
Now we know.
Oh, we know.
All right.
Thank you.
Thank you. Great case. Nicely done.
Thanks.
As we're switching to the next speaker, I just wanted to do a shout out to some of our friends. Dr. Jeff Kaplan is online. Really pleased to have Dr. Barrera, Mohammed Sohail, and our very good friend Tarek Rodwan. Shout outs from Seattle. We miss you here. You're a great guy. Did a great job in Maine. So many other good friends and colleagues. Dr. Brooks, thank you for joining us. Dr. Özdemir, it's nice to see you here, and really pleased to have you. Hopefully you'll find today's cases and discussions interesting. We appreciate your interest and support. Next is Dr. Ravi Nuna. He's plugging in his computer. And as you're plugging in, I know you can multitask very well.
Yep.
Can you just tell us a little bit about smoking? What should we know about smoking?
So we recently made an analysis on smoking with the group here at SNI, and we essentially found that while some of the literature we already know that smoking obviously increases the risk of non-union, we were quite surprised by how severe that effect is, especially in the thoracolumbar spine and especially in fusions of 2 or more levels. So especially in fusions of 2 or more levels or thoracolumbar fusions, smoking carries between a 2 to 3 times increased risk for non-union.
So this is a big deal. Why has this not been published before? Before you answer that, and you can start thinking about the answer, just for the lay people in the audience, what's a meta-analysis? What kind of scientific methodology is that?
So a meta-analysis is essentially a quantitative synthesis of as many clinical studies as we were able to find on this topic. So we searched through a number of medical databases and compiled and synthesized all the available literature on smoking and its effect on non-union, whether it was in the cervical spine or the thoracolumbar spine or all these other risk factors that may play a part. And then we analyzed them in terms of their outcome data and if they were sufficiently homogeneous enough to compare. And when we made that assessment, we then proceeded to an actual quantitative analysis.
So again, repeat the numbers one more time because they're pretty shocking. So what's the increased risk of smoking?
So the increased risk of smoking, it's at least two times increased risk of smoking for non-union. At least 2x, up to 3 times though.
So in your research, how did you define smoking? Does it count if you say, hey, I cut back, doctor, I'm down to 1 cigarette a day. Does that count?
So we would register that patient as a smoker, actually. So, when we started to do this study, we wanted to make sure that we used a highly restrictive definition of smoking. And we elected to use any smoking within 1 year of the index surgery.
So our academies always tell us, both neurosurgical and orthopedic, to tell patients to stop smoking. And is it smoking that's the problem, or what kind of a chemical factor is the problem?
I mean, it's most likely nicotine. It's the nicotine use.
It's the nicotine derivatives.
Right.
And what do they actually prevent?
As far as I know, it prevents bone healing.
Yeah, but what? When I gave that little rundown of check factors, what's the problem?
I think it compromises the vascular supply.
Bingo. It limits the vascular arborization, so that sprouting of little branches. So what part of the bone healing of those 4 phases gets impaired?
Maybe it's second.
Number 1 and number 2, but number 1 is the key thing. Clearly gets impaired by nicotine. It's a very strong chemical signal that impairs that arborization. So we have to tell patients to stop smoking, but if we want to be really clear, 3 months is a minimum, 6 months is much preferable. A year is probably the realistic fact until the various side chemical variants are out of the system. So carry on, thank you.
Oh, great. Thanks, Dr. Chapman. So our case that I wanted to present today was a 65-year-old male. He has a history of a factor V Leiden, and he had subsequent DVTs from this illness. He was chronically anticoagulated, also had a significant diabetes and advanced osteoarthritis of the left ankle, which left him debilitated in terms of his mobility. He was also obese with a BMI of 36. He initially presented to our spine clinic with a debilitating low back pain in addition to bilateral leg pain, which was most severe over the last year. He also reported weakness in the left leg, which was partially chronic in terms of his left foot drop, but also progressive in terms of proximal hip flexor weakness. He reported no bowel or bladder dysfunction, and notably, he had a previous surgical history of a T9 to pelvis fusion done at another hospital with the inner body placement at 4 levels. On physical exam, he exhibited significant weakness in the left lower extremity, and most notably, he did have a left foot drop. He had trialed an AFO previously, but said it didn't help him much. His reflex exam was largely normal. This is some preoperative imaging of this patient, and as you can see here, this is his thoracic sagittal cut here, and this patient began to develop proximal junctional kyphosis in addition to stenosis at the proximal segment, or the upper instrumented level +1. This is a myelogram here, and then as you can see on the radiograph on the right side, is sorry about that. We're having some technical difficulties here. All right. This is an MRI of the same patient. As you can see here, he does have a significant stenosis at that level. And then here's some representative images of his lumbar spine. Notably, he has non-union at L5, S1, in addition to bilateral rod breakage, as you can see here on the radiograph. Here's some images.
Go through it again, just bit by bit so we can see the lateral gutters. Ravi, when do we know that we have bone healing? And then stop at something and show us where there's a non-union so that everyone in the audience can see that. Yes, so how long does it take to establish a spine fusion to be united?
That question, it's a great question. It hasn't been definitively answered in the literature, but I think most assessments, we use 1 year to assess bone healing, preferably on a CT scan.
I should ask Dr. Hayumi again how long it is in orthopedics, like for a femur, but this is an extraordinary thing. So, Puya, you don't have a microphone, do you? I'm gonna give you a microphone. Come to my microphone. So, give us an outline. Femur fractures, the long bone. How long until we call it a non-union? That's pretty well established, right?
Absolutely. So again, controversial like it is in spine, but for non-union, some people say 6 months, but the more commonly quoted number, I think, is around 9 months. If there's no evidence of healing at 9 months on radiograph, that's when we get a CT scan, I kind of work it up. But not 9 months was a number that I've heard mostly.
What, from your orthopedic perspective, is so different about the spine, specifically thoracolumbar spine, specifically, again, the posterior environment that makes it so different?
Part of it is going to be the soft tissue environment and also the amount of motion. With femur, obviously, we completely stabilize it, completely remove any type of motion and let it heal. But with spine, that's the goal. But there's going to be, especially at the thoracolumbar junction, you're going to still have some motion. I guess that's what you're getting at. I'm not sure.
Talk about, so first of all, loading is a big deal. So for femur fractures, loading is very important. You have a very effective loading environment. So it creates this piezoelectric effect that stimulates calcium channel communication, that stimulates bone healing, okay? Now, in the spine, what's different there? Especially if you have a posterolateral fusion like what Ravi showed there. What's different with that posterolateral environment?
Compared to a femur, for example, is that what you're getting at? I mean, there's going to be loading as well in the posterolateral. And like I said, the motion and the amount of loading is going to be a lot more significant in the lower lumbar and the posterolaterals.
Basically there, the main load transmission goes to an instant center of rotation, and that's in the posterior third of the vertebral body. So the vertebral body would actually be a better healing environment because it loads better. The facet joints just have roughly, and they share that, about a third of the load transmission of axial loading. They load more in rotation. So this is the thing. So in your analysis of Dr. Nuna's picture here, if you can just stay in that left-sided sagittal frame, what can you, by word use, identify in terms of that L5S1 area?
So there's evidence of some, I can't see the screws, but looks like there's some haloing around the cage. There's really no bony bridge anteriorly, so there's definitely concern for non-union at that level at L5S1.
How do you describe the host response around that cage?
It's hypertrophied. If you want to use orthopedics, this would be kind of hypertrophic non-union that is forming the bone, but probably something is, so there's the biology, but the amount of stability is not adequate to lead to union at that level.
So there's radiolucency with resorption around the cage, and then there's hypertrophy with a large syndesmophyte growing anteriorly. If you don't mind, Ravi, can you scroll through the side so we can see the sagittal cuts to the facet joints?
Oh, yeah, it's going to be on this one.
If you can, if it's not too difficult. Oh, yep. So right there, if you go back to the facet joint level, please.
Oh, I can't scroll. It's just a,
Okay.
It's a looped video.
So what do you see in those facet joints?
There's also some haloing around the screw heads, around the tulip at that 5-1 that I can see.
Facet joints have not bonded.
Yeah, there's no union at that level. Yeah.
What do you make out of the, what do you make out of the pelvic fixation having failed? What's going on there? And is that an unusual finding? What do you think happened there?
So as you have non-union at the level above, all the loading and all the pressure basically ends up, all the load is on the pelvic screws. And there's definitely, it's not surprising that it failed.
So that's a big deal. So do we try to fuse the pelvic joints, the SI joints?
So in a situation like this, when at least the non-union and the level above has failed, and there's definitely, when you go back, that's something to consider. I've seen people do the SI fusion bilaterally as well, in addition to changing the pelvic screws.
One more question. When you see radiolucency around a hard rail like that, what is a adjuvant concern that is very significant as you approach this patient? What possibility do you have to look for?
Biggest thing is an infection, so you got to work this patient up for an infection.
And when we hear infection, we always think about sepsis and a super sick patient. Is that what we're talking about here, or is it something different?
It can be indolent. It doesn't have to be a full-on septic presentation. It can be something that, like a P acne that we've actually been seeing a lot more. That patient can come in and not sick looking, and numbers are not looking too bad, but the kind of a low-grade infection can lead to this non-union.
That's a really big point. So when I see non-unions, I always get a sedimentation rate, the C-reactive protein, and nutritional status on the patient, so nutritional labs, to check for a low-grade underlying infection. and I want to make sure their nutritional status is optimized. Thank you.
Thank you, sir.
All right, so Rod, this is your patient. So what are your approaches? What are your concerns? You have a problem at the bottom, you have a problem at the top. Do we tackle everything? Do you tackle one? How do you go forward?
I think, do we have the upright film? So he developed kind of camptocormia, literally where he could not stand up. And I think it's because of the lumbosacral junction. And he just became bedbound, and his wife told me, he gotten to the point where he just literally used a wheelchair to get around the house. So, and obviously you saw his medical history, so pretty significant risk factors for non-healing. He just got to the point where he didn't smoke, but he had factor V. He's morbidly obese, had multiple spine surgeries, and he just literally got to the point where he couldn't stand up. So I think in this case, you have to think about realigning him, and obviously bone quality. You can see the bone density is not great. The possibility of an infection, anticoagulation, all these things. I think we worked him up for like almost a year before doing surgery. And, these are exceedingly difficult cases. And I don't think it's going to be his last surgery. So.
Great. Thanks, Dr. O. So as Dr. O mentioned, some of the operative considerations for this case was this patient had obviously developed a PJK. He had a focal kyphosis of 20 degrees. Most of the literature uses a definition of greater than 10 degrees. He had a chronic nonunion at L5-S1, distal hardware failure. And then on the myelogram, there was also a concern for pseudomeningocele because there was a pocket of fluid that had a contrast extravasation. So in terms of our surgery, we elected to place a preoperative IVC filter just because the patient wouldn't be able to remain on this chronic anticoagulation. We planned for a T5 to pelvis posterior fusion with a 3-column osteotomy performed at a T8-9 and L5-S1, in addition to a revision laminectomy, T8 to 11 and L3 to S1. And then we also performed Smith-Peterson osteotomies from T12 to L4. We used a host of biologics in this patient just because of his risk of developing non-union down the road. We used BMP, we used demineralized bone matrix, as well as all the local autograft that we were able to harvest in the case. So some representative CT imaging here. We were able to improve his focal kyphosis from 20 degrees to 8 degrees. As you can see here, he's basically much more upright than he was. And then we also replaced the interbody, or placed an additional interbody, at L5-S1 in addition to his previous interbody to assist in his fusion here.
Did you do an SI joint fusion?
So we actually did. We deported like crazy. Just put bone graft, allograft, and off-label bone morphogenic protein.
Got it. Okay.
So he did great post-operatively. He reported significant improvements in his leg pain, gradual improvements in his mobility and left leg weakness. And we're still waiting to see him in terms of his first follow-up. Some quick literature review. This is a recent publication from the International Spine Study Group looking at the risk of development of PJK in the Global Spine Journal. They looked at historical literature to basically come up with a scoring system for risk of PJK. This was in 417 patients with a minimum of 2-year follow-up. PJK was defined as greater than 10 degrees of focal kyphosis from the upper instrumented level to 2 levels above that. This study reported a 43% rate of PJK. And then these were the 4 parameters that they used for the scoring system. That included age greater than 55, whether they fused to the pelvis or not, whether they fused to the upper thoracic or the lower thoracic spine, and then if the lordotic change was less than or greater than 10 degrees. Surprisingly, the most important factors were whether a patient was fused to the pelvis or not, whether they were fused to the upper or the lower thoracic segment or not, and their age. The correction was actually the weakest correlation here. As you can see on the table on the right, the odds ratio of 1.6, which is still significant, but obviously significantly less than the other risk factors that this study investigated. They also validated their scoring system, as you can see here on the left. And while it is associated with higher rates of PJK, it would appear that scores of 1 or 2 may not be as valuable as scores of 3, 4, or 5 in this preliminary scoring system.
Great. Any other learning insights? So you looked at smoking, for instance. Now I'm going to talk about diabetes. Is diabetes a problem for bone healing? And if so, why?
Similarly, diabetes can also compromise the vascular supply and impair bone healing. So I would say absolutely diabetes is a huge concern.
There was a recent very large-scale database assessment from our Academy for Orthopedic Surgeons, and they identified that by far the leading complication burden comes from diabetes. So what do we do in clinic nowadays to try to minimize that risk, and how effective is that? What do we ask patients to do?
Well, preoperatively, we counsel patients extensively in terms of their nutritional status. So we obviously check their HbA1c, we check all their laboratory markers, and we want to make sure that they're seeing a PCP or somebody's following them regularly for their diabetes. And we want to make sure their diabetes is essentially very well controlled and that it's going to remain well controlled postoperatively during the healing process.
So the A1C is kind of what we commonly use. What do we want it to be at?
Ideally less than 7, or less than 6.5 even.
Yeah, 6.5. We want to try to be below that. So this is a number that we nowadays use. But again, do we have any evidence that it actually reverses that lack of blood vessel supply, the microangiopathy? Does it actually get reversed?
That I'm not aware of.
I don't think so. So I think there's a permanent damage, but the longer somebody has had an out of control A1C, the worse their microvasculature is going to be. The bigger the burden on us to do a perfect job and then have some luck also.
Right.
Nice case. Thank you for showing that.
Thanks, Archie.
And there was no infection, right?
No infection, no.
Next, we have Dr. Rick Price. He'll introduce himself, and he is put together. He's getting the right gadget. He is using a different laptop, and he's going to show a patient of mine who has had bone healing challenges. Good morning, Rick.
Hey, good morning.
Did you get all the slides together?
Yep.
All right.
Hey, I'm Rick Price. I'm one of the spine fellows.
Can you
here.
speak into the microphone a little bit more? We got a.
Yeah, 1 second. I'm having some issues. Hey, do you help with this? I don't know why it always does that.
Yeah, that's weird. Let's just try to. I think what happened is. Oh, geez. I'm sorry, this always seems to happen.
There you go.
All right.
Yeah, we're in business now. I'm Rick Price. I'm one of the spine fellows, originally from WashU, where I did my neurosurgery training. And I'm presenting a case that I did with Dr. Chapman here recently that ultimately had to be revised for bone healing issues due to smoking. So this is patient TT. She's a 57-year-old female. She's initially reported to clinic about 2 years ago now with bilateral back pain that radiates in a radicular pattern down the left leg. She denies any bowel or bladder incontinence. She does have some weaknesses, a typo there. Her past medical history is significant for a C6 and T1 posterior spinal fusion done years and years ago. But then her social history is actually rather relevant to this talk. She had a 25-pack-year history, recently quit smoking before coming to clinic, but it has also a history of substance abuse, alcohol, marijuana, and opiates. On exam, she mobilizes with a scooter, and then her appearance is much older than her stated age, likely, I think, probably due to some of her substance abuse issues. She's full strength in the upper extremities and right lower extremities, but she does have some weakness in the left lower extremities, in the iliopsoas, and then dorsiflexion, and then plantar flexion as well. She has no pathological reflexes or clonus and reflexes are normal. This is her upright x-rays from at that time. As you can see, she has considerable scoliosis here. The right side of the Cobb angle at 30.5 when it's measured from T12 to L5. Pelvic incidence is about 58 degrees. Her lumbar lordosis is 31 degrees for a mismatch of about 30 degrees total. And her SVA, she's just slightly pitched forward about 6 centimeters. This is her imaging at the time, a CT showing lateral athesis, 4-on-5, and considerable bony changes with degeneration and osteophyte growth. And this is a T2 sagittal MRI. Again, it's from the left side, the right side, the middle of sagittal imaging, showing multi-level stenosis, as well as reiterating the scoliosis that we saw in the plain x-rays. Looking at the disc levels from L12 to L45, both the CT myelogram on the bottom and the T2 MRI on top, you see multi-level stenosis that's worse on the left side. You see here, which is consistent with their symptoms, as well as look at the CT myelogram where you get very little flow through these levels, especially at 2-3 down to 4-5. So the plan for her about 2 years ago was taking her to the OR for a 2-stage procedure. The first stage was a left side up L4-5 XLIF. And then the next day took her back for the more extensive posterior surgery, where they did a T9 to the pelvis fusion, laminectomies from L1 to S1, and then 3-column osteotomies at 2-3, 3-4, and 5-1 with inner-body cages, and then also use of BMP. And you can see here on the right side that we got really good correction, restoration of lumbar lordosis, and straighten out the scoliosis. And the x-rays at the time, we're really happy with, especially when you compare them to the preoperative imaging. You can see here where she's much straighter, and then better restoration of the lumbar lordosis. She was kind of lost to follow-up. There was several appointments that she missed, but she had a fall and had worsening back pain after the fall. And this is about 1 year post-op. And she was found to have broken rods down here at about the 3-4 level. It's kind of hard to see, but it's pretty evident right here, where she has broken rods on both sides, actually. And then you can see that some of her construct from the broken rods, she's redeveloped some of the scoliosis. And in the interim, since we had last seen her, she had started smoking again. Looking at the CT, you can see non-union, the inner body here at 4-5, also 3-4, and then further degeneration and just horrible bone quality, likely, we think, due to her smoking again, where she had a non-union. And then if you look at several of the screws on the coronal imaging, you can see significant lucency, for instance, this right here. I'll come back to this at the end of the talk on how we dealt with the widened screw track. And then the CT myelogram shows some additional compression, some of the levels.
So Rick, if you compare what has happened at 2-3, 3-4, and then this large gap at 4-5, and then at 5-1, there's a striking difference. Rod, this is a case that we had done together 2 years ago. So describe what happened in the cages at 2-3 and 3-4 relative to 4-5.
At 2-3 cage looks pretty good. Like it's fused mostly. At 3-4, there's not as much bony growth, but then here at 4-5, you can see the clear lucency and subsidence of the cage, showing non-union.
So I concur. So one of the big things in industry was to have these PEEK cages, that plastic material to be radiolucent so we can see bone healing. So 2-3 has formed some bone. Do you mind putting your cursor right on those little bony kind of jags that go through? So it's not built through, but there's an attempt at the body to kind of mature through that plastic. And I want to point out the plastic graft is like the Great Wall in the Game of Thrones. They're impenetrable for body cells, no healing whatsoever. 4-5 has not had any bone maturation worry. So Rod, when you do these XLIFs, what kind of bone graft material do you put in there?
I mean, usually we use allograft.
Can you speak?
Usually we use allograft.
So is any special allograft, cell-based, anything like that?
No, just demineralized bone matrix.
Okay. In the interest of time, why don't you go ahead then?
Okay. So we planned a revision surgery for her. Fortunately, we had to wait for her to quit smoking again, but then also the surgery got pushed back due to COVID. But we recently were able to operate on her and revise this. So for the revision surgery, we upsized the loose screws. We went through all this. We opened up the whole construct, went through screw by screw, and then upsized most of the screws. Most were loose and needed to be replaced, even if there wasn't much lucency on the CT scan. There's several pedicles that we added additional screws to that were not in the initial construct, and then added 2 additional pelvic screws, one on each side for a 4-rod construct. We also removed the midline scar to do a more thorough decompression of all the nerve roots, but we were unable to revise the L4 interbody where there's a nonunion from the back because the bones had settled so much to each other, or that the passageway was kind of blocked by nerve roots. So we thought that we would potentially cause a deficit trying to revise that. So we just revise the screws and then do the 4-rod construct with the plan of coming back at a later date to do an ALIF to remove the interbody. And you can see here the postoperative imaging where, just go back into comparing to this on the left is the pre-op imaging from about a year ago, and this here on the right is what we did earlier this week, where you can see the additional pelvic bolts with the outrigger rods, and again, restoring some of the lumbar lordosis that had been lost from the broken rods, and then also straightening the scoliosis.
So thank you for that presentation. Oh yeah, it shows that, yeah.
And one thing that we did in this case, which is unique, that the Dr. Chapman showed me that I wanted to point out was how to, a bailout technique for when you have a wide track. This here was the L4 interbody, or L4 level, and you can see a lucency around the screw that we measured preoperatively. It's about 12 millimeters of lucency. And as far as I know, there's no device manufacturer that makes a 13.5 screw or something that would be able to fit into there. So a technique that we used was taking a fibular allograft and cutting them up in like these matchstick sizes. So if you imagine this black circle being the pedicle tract and putting these matchstick-like bone, fibular bone in it to where they pop out a little bit so that you don't drive them through. And then we started with a 4-5 tap and then upsized to make a new track for the fibular bone chips. And up to, I think we went up to 6.5 and then putting a 7.5 screw in. And then if you look here closely, this didn't project very well, but this is that new level, this level here, this L4 level that you can see here with this wide track. You can see the screw in the middle, and then the fibular chips that are occupying the rest of the previous wide track. So I thought this was an interesting way to bail out from a wide track screw.
And how was the screw purchased?
It's excellent. We got a 7.5 screw in there, and it felt like putting in normal bone.
Great. Rod, do you agree with our plan to come in from the front again? And how difficult is it to do an ALIF, an anti-lumbar interbody fusion, when we've previously done an XLIF?
I mean, I think it's a good plan.
Microphone.
I think it's a good plan. I think this patient is healing and impaired, obviously, so you got to get something in the front.
Yeah, we'll do that. Rick, it's a great talk. Thank you. And thanks for ending on time, and great presentation. Dr. Campion, can you hear us?
Yes.
Hi.
Good morning.
Dr. Campion is a PhD. He is calling in from the Netherlands. From which city?
Utrecht.
Utrecht. Fantastic. Yeah. I have good friends in Utrecht at the medical school there. Dr. Campion is a PhD, and he is from Holland, as you can hear and see. He holds a PhD in materials engineering from the University of London, He's published quite a bit, and he's here in a commercial function speaking on behalf of a company called Chorus that promises something better than normal allograft chips that we put in so often that you saw here. And obviously, we're very curious to hear your thoughts in terms of what's going on. And previously, I don't know whether you're part of our conversation, talked about the piezoelectric effect and the biomechanical impact of calcium channel communication in bone cells. So is that BS? Did I run a smoke screen on our fellow, or was there some truth?
No, you hit the nail on the head there. Good job.
So bone cells have some brains, right? They have feelings.
That's true. I'm going to come on to that in a minute.
All right. So anything else I should introduce you with?
No, that's a great introduction, a very kind introduction. Thank you. And full disclosure, I am a full-time employee, a paid employee of Curos Biosciences, and the technology I'm going to talk about today is a technology from that company. So can you all see my presentation? Yes, okay?
It's there and we can hear you. If your microphone can be turned up a little bit, that'd be probably good, or get a little bit closer to it. And your background shows up really well.
Let me just turn up my microphone then.
It looks something out of a dystopian sci-fi movie.
So this is the subject of my talk today, actually, the background behind me. So thank you very much to the organisers, everyone at SSF, for the invitation to talk today. And a special thank you to Ashley, who yesterday helped me get prepared for this presentation. Arguably, there are names within the spine community who have contributed more to patient treatment overall, but no single person has contributed more to maximising the efficiency of fusion biology than Marshall R. Urist. Imagine if he had not discovered BMPs and the impact that that would have had on all of the patients you have treated in the past and may treat in the future. Discoveries such as his back in the 1960s happen only once in a generation. And what I'm going to talk about today has the potential to be one of those discoveries. That discovery is not that of George D. Winter, however, he is part of a story. Only 4 years after Urist's seminal work, George and his team discovered that they too could stimulate bone formation in soft tissues in animals. But this time he did it with a polymer sponge rather than with BMP. Now, George D. Winter went on to found the European Society of Biomaterials and served as its president until the 1980s. Since the 1980s, other materials have equally been shown to be capable of stimulating bone growth in these ectopic defects in animal studies. For example, hydroxyapatites, which are highly crystalline calcium phosphates, originating either from coral or from bovine bone, as they were tested in the 90s. These have also been shown to be able to form bone in soft tissues. Ripamonti was a leading research in this field in the 90s. Other materials since then have also been shown to share this propensity. So biphasic calcium phosphate, bioglass, and even titanium, a metal, have been shown to form bone in these defects under certain conditions. The really interesting work in this area has focused on calcium phosphates with specific structural characteristics. And over the past 20 years, we have learned a lot about how these characteristics influence osteogenic potency. We've learned a lot over the last 50 years of research since George D. Winter's original research on polymer sponges. So what's the takeaways? Besides BMP, other materials have the propensity to form bone in these soft tissues of animals. And this includes an array of materials, polymers, ceramics, and even metals. And this effect has been demonstrated in all manner of species of animals, from mice all the way through to non-human primates. So how does Curos Biosciences, the company that I work for, fit into this story? We at Curos have over 150 collective years of research, specifically in the field of synthetic biomaterials for bone repair. On the screen, you'll see Clemens, our chairman, Joost, our CEO, and Yuan, our research manager. Now, there's no team on earth who has dedicated more of their lives towards improving the standard of care for bone grafting. For example, if you have used a synthetic bone graft sold in the past by Isotis or Integra, C-Spine, Apotec, Baxter or Nuvasive, there's a high chance it was developed by someone who currently works at Kuros. And for 25 years, this team have been uncovering the precise relationship between the structural and chemical properties of bone grafts and their potency in ectopic defects. This is all with a view to improving the outcomes in more clinically relevant orthotopic defects. As an example of their contribution in this field, the team have published over 40 publications specifically evaluating the relationship between a material surface and its osteogenic potential. What key observations have our team made over the last 25 years? Well, bone formation is typically via the intramembranous route, which is in contrast to the endochondral bone formation route that we see for BMPs. And this tells us a little bit about the underlying mechanism. And the structural properties of a material are incredibly important. Removing certain features can completely eliminate the bone forming potential, whilst enhancing them can significantly improve the osteogenic potential. And lastly, and most critical to this talk, are that multinucleated cells of the immune system appear to be involved and relevant in the cascades of events immediately after implantation, but before bone starts to form in these soft tissues. So why and how is our immune system so important in our observations? Well, our skeletal system and our immune system talk to each other constantly, but more than simply talking to each other, the two systems are inextricably linked. For example, and as we all know, cells of the immune system, the white blood cells, originate from the bone marrow itself. The study of the interaction between these systems is known as the field of osteoimmunology. And this is the field that has exploded over the last 20 years due to the discovery I want to talk about today. So here goes. Imagine for a second if there was one single cell type in the body that could simultaneously be responsible for the following in bone: clearing debris from sites of tissue injury, mechanically remodeling the extracellular matrix, upregulating angiogenesis through endothelial progenitor cells, releasing stem cells from the tissue matrix to promote tissue repair, upregulating mesenchymal stem cells to form bone via the prostaglandin pathway, stimulating the production of collagen by osteoblasts and laying down, promoting them to lay down osteoid, and even the same cell being responsible for fusing together to form osteoclasts of the osteogenic lineage. Well, ladies and gentlemen, you need not imagine this any longer, because at the turn of the century, Charles D. Mills, who you see on screen now, discovered that a cell type of the immune system can indeed fulfill all of these roles in bone simultaneously. And this is down to their highly plastic nature. What does this plasticity mean? Well, I will get to that in a minute. Let's first consider the immune system's response to injury. We have white blood cells called monocytes that travel around the bloodstream and react to sites of tissue injury. What they are sensing are cytokines which are released by cells in injured tissue. Now, that injury may be caused by trauma, by surgery, or by the implantation of the material. And when these cells become resident in the tissue in response to that injury, they differentiate into macrophages, who are the first responders of the immune system. Excuse me. So macrophages have historically been thought of as the bad guys, the villains, the rogues, because they're always present in high numbers at sites of inflammation. But more recently, scientists have discovered an almost bipolar response from these cells. They are responsible for both inflammation and its resolution all at the same time. But how can this be possible? The answer is that macrophages are highly plastic. which means they can change their phenotype depending on what's happening around them. If they flip to a M1 macrophage, they are pro-inflammatory. Now, these macrophages are responsible for the early tissue response in healing. They upregulate pro-inflammatory fibroblasts, and if they become dominant, they will lead to fibrosis. And in the context of a spine fusion surgery, such as the cases we saw earlier today, that could mean the formation of scar tissue and eventually leading to a non-union and a pseudoarthrosis. If the cells, however, flip to an M2 phenotype, the M2 macrophage, they are pro-healing and anti-inflammatory. These cells are responsible for wound repair and for suppressing the inflammatory response. So the discovery of this subtype of macrophage and the discovery of their plasticity by Charles D. Mills has fueled the explosion of research in this field. If we can promote, let's just consider, the healing rather than the inflammatory response of these cells, then we can surely enhance the reparative process that we want to happen in these tissues after injury. So our scientists at Curos realized the potential of these cells and have indeed demonstrated that we can manipulate them for an enhanced response to our bone graft technologies. We know that previous grafts have made it onto the market with claims that are based on in vitro studies that did not really translate into equivalent clinical outcomes. So we at Curos have decided to take a more evidence-based and translational approach that I will now walk you through using the work of our scientific affairs manager, Luc van Dijk. So based on our early exploratory work in these ectopic defects, these soft tissue defects in animals, the work of Yuan that I described earlier, Luc set about evaluating naive monocytes and how they responded to materials with various surface features. These cells were isolated from buffy coats donated from walking, breathing human beings here in the Netherlands, and then they were cultured on the surfaces that you see on screen now. On the left, the material has needle-shaped features that are submicron in size. On the right, the features are about 10 times bigger, flatter, and spherical in shape. Now, this is quite typical of the bone grafts which have been on the market for since 1982 when Kronos was launched. Using scanning electron microscopy, it was immediately obvious that there were striking differences in the way that these monocytes would react to the two different materials. On the cells with a needle-shaped surface, they were elongated, flat, and spread out. And they were doing something quite interesting, which is fusing together. The cells on the flatter, more conventional surface were smaller, spherical, and not spread out. We already know, based on the research of other global experts in this field, that the cells on the left are displaying a pro-healing phenotype, whereas the cells on the right are displaying a classically activated pro-inflammatory phenotype. Now, we were able to confirm this using both ELISA assays of the cytokines, the proteins that are secreted into the media by these cells, and by performing quantitative PCR of the DNA in the cells. And what you're seeing on screen now is some of that research. Remember, this is data from cells that 4 days prior were flowing around the circulatory system of a human being here in the Netherlands. What you see in the top two charts is an upregulation of the M2 markers in these cells, and in the bottom two charts, there was no difference in the M1 markers between the different materials. So next, what Luc did was harvest the cytokines, the protein soup that these cells had secreted, and then fed that soup to human-derived mesenchymal stem cells. The cells were cultured on tissue culture plastic, so the only factor that he was measuring was the effects of this protein soup on the cells. And what he found using this ALP assay was that stem cells that were fed the soup from the macrophages cultured on the needle-shaped surface exhibited greater osteogenic differentiation compared to the control. This is where it starts to get really interesting. So what he did next, he took the same protein soup and he fed it to human-derived endothelial cells, so derived from the umbilical cord, in a well-known angiogenic assay. And lo and behold, he found the same kind of outcome. Soup from the macrophages that had been seeded on the needle-shaped surface led to the development of an extensive angiogenic tube network in this assay. The length of the tubes and the number of junctions was far higher for these cells than on the control. What we're talking about here is the propensity of the material to drive revascularization, which, as Dr. Chapman mentioned earlier, is a critical step in normal physiological bone healing. What our scientists did next, no one had ever tried before. They took the same materials that Luke had tested and implanted them into a pocket created by a blunt dissection of the paraspinalis muscle in large animals. So the materials were in a soft tissue pouch in a site which is close to the spine, but not in contact with host bone. This model in canines is known to be quite challenging because it's the least successful in terms of bone formation of all of the large animal muscle pouch models. The team waited for 3 weeks and then removed the materials and performed the same cytokine analysis that Luke performed on the bench top. What they found was that the immune cells that had colonized the graft from the living tissue in these canines were predominantly of the pro-healing M2 macrophage phenotype. And the opposite was true for the control materials. We found more classically activated pro-inflammatory M1 macrophages. So the same team left the materials in the same defects in these animals for a further 9 weeks, so 12 weeks in total, and discovered to their amazement that this effect was so potent that we were able to demonstrate the formation of bone in soft tissues of these animals. The tissue demonstrated all of the typical features of lamellar bone, with osteoblasts laying down osteoid, osteocytes trapped in lacunae, and osteoclasts resorbing and remodeling the graft as well as the bone. This is in contrast to the more conventional bone grafts where we find only fibrous tissue. I show 2 examples on the screen here, but we have tested a whole multitude of these materials. This is all published work. This particular work is published in the Journal of the European Cells and Materials. Now what I've done here is blow this up on screen for you to demonstrate what we're talking about. Here's the same image at higher magnification that hasn't been cropped. Bone was formed throughout the implanted graft and was in direct apposition to the material surface. But importantly, bone was only formed where the graft was implanted. There were no bone spurs, no runaway bone formation, and no osteolysis. And this is an observation that we make in all of these models, and this has been repeated time and again. There is a complete mature bone ossicle of about an inch and a half in diameter that has been grown within the muscle of the animal. And we even see the development over time of a pseudocortex. So I mentioned earlier that we at Curos believe in translational research, in proving that what we see on the benchtop translates into larger animals and then into humans. So we performed, with the help of Professor Bill Walsh in Australia, a clinically relevant model. In this example on screen, we demonstrate the formation of equivalent fusions to autograft for this material in an instrumented model of posterolateral fusion. In this example, the graft was laid between the transverse processes and not over the facets in this posterior aspect. And it's not in contact with the vertebral body. So we're not relying on conduction from the bone along the length of the material. Now this model, or this approach, has been validated by Lindley et al. As being a challenging model, even when autograft is used in the same defect. We used radiological, biomechanical, and histological endpoints to evaluate the fusion. So these are endpoints that we can rely on using animal models that you don't get the advantage of using, obviously, treating patients. What you can see on screen now are parasagittal sections through the center of the fusion bridges over a 26-week time course. Over time, bone grows throughout the bridge, and by the later time point has replaced much of the graft. But what was noteworthy in these clinically relevant models was that we observed bone forming in the center of the fusion bridge as early as 6 weeks. This you can identify here on the left image as areas of fuchsia tissue that are visible in the center of the bridge, but not connected to the host tissues. So what we see here is we see both creeping edge repair and bone growing throughout the bridge. This observation is in contrast to conventional materials where bone only grows through creeping edge repair from one transverse process from another and meeting in the middle. Now the risk of this creeping edge repair as being the only mechanism for bone growth is that a layer of tissue, fibrous tissue can form in the opposing fronts of bone. And that can develop into a non-union or pseudarthrosis. When we compare the outcomes of the same material to other commercially available grafts, we see a striking difference in the biological response. By multiple endpoints again, we find that the fusions are more uniform, solid, and stable. In the example on the screen we see here, at 12 weeks, both autograft and this material, the top two materials, are able to complete a complete uniform and solid fusion bridge. Whereas the other materials that we tested below, these are commercially available bone grafts based on the left on bioglass and on the right, a tricalcium phosphate collagen bioglass composite. All we see there is an inflammatory-like response to these materials. Higher magnification images of this tissue response can be found in the paper cited at the bottom of this page. We at Curos are confirming with an extensive program of level 1 studies in the spine the outcomes that we have uncovered in these clinically relevant studies in animals. Several studies have been initiated and can be found by heading to clinicaltrials.gov and searching for Curos Biosciences. And at least 5 of these studies will be of level 1 quality, meaning that they are randomized, they are powered and contain an active comparator control. And this includes, in one case, in 2 cases, autograft, and in another case, a cell-based allograft. So in conclusion, time will tell whether the discovery of Charles D. Mills will surpass that of Marshall Urist in terms of the impact that it has to fusion outcomes following spine fusion surgery. But for now, I hope I've convinced you of its relevance to your future practice and provided a real-life worked example of its application to achieve more reliable fusions. In the meantime, I encourage you to learn more about osteoimmunology from these papers. And of course, you can do that by getting in contact with our scientists at Curos to learn more. I love a good analogy, so I would like to end this presentation with an analogy. Think of stem cells as seeds and macrophages as farmers. For a long time, researchers focused on the stem cell. There is no doubt that they are crucial for tissue repair, just as seeds are for growth of a new crop on the farm. But everyone knows you can't just throw seeds into the dirt and expect them to grow. You first need to plow the dirt, you need to feed the soil, you need to carefully plant the seeds, and you need to provide them with all the nutrients necessary to grow. This is the role of macrophages in tissue repair. One seed leads to one plant, but one farmer or a handful of farmers can cultivate 1 million seeds into a blooming crop if they are given the right tools to do so. In this case, the tool is our material surface, which we have reliably demonstrated unlocks a previously untapped potential to stimulate stem cells and form new bone throughout our graft for a more predictable outcome. The application of this science is, of course, far-reaching, way beyond just spine fusion alone. Thank you very much for your attention. The technology I described today is a commercially available product. Please reach out to us, follow us on LinkedIn, or come to our website to find out more. Thank you again for your time and attention. I'll now hand back to Dr. Chapman.
Dr. Campion, thank you so much for your very eloquent and visually compelling discussion. So 2 quick questions. We only have about 5 minutes left, so I apologize, I have to jump on the next meeting. So if you will, please go back to that regeneration, not inflammation slides, like 4 slides back. By the way, those stem cells, they look more scary than the coronavirus.
They do close up, don't they?
Yeah,
you mean
yeah, just
this
stay
one?
with this is a yeah, excellent. Yeah, that was a really compelling picture. So now help me. So this whole field of osteobiologics has become really complicated. It's a very big growth zone for industry. I'll realize that as we're ending the metal era, we're going into the biologics era now, and then into AI and all sorts of augmented realities. But let's go to the bone healing here. So I do know that a certain product called Infuse, BMP, is very effective. It does form bone. I do strongly think that based on empirical information and the research I've done into this area, that this main effect may actually be inflammatory. It creates a very well known inflammatory response. So that seemed to be a good thing for BMP. Now, if I hear your lecture right, you tell me that this inflammation is not desirable and can kind of lead to fibrous formation. So please kind of differentiate the statement, regeneration, not inflammation. Yeah. One more time for the slowpoke that my brain is.
Yeah, so actually, it's a great question because it's a complex, you know, all biological systems are complex and there's always a level of detail below what I have time to present in 20 minutes. But essentially, inflammation is a good thing in the early stages of tissue repair. The formation of a granuloma, the recruitment of and differentiation of M1 macrophages is actually a good thing early on in the 3 days following an injury. And that's because they actually recruit stem cells to the site of tissue injury, and they release cytokines, which enhance the initial inflammatory response. The key is to make sure that that response is switched from a predominantly classically activated M1 response to an M2 response. And there are different ways to make that switch. There are chemical and physical cues that can help cause that polarization from M1 macrophage phenotype to M2 phenotype. The well-known chemical activation of that is with interleukin-4. And what I've described today is a more physical change in those cells. Once the cells attach to our surface, they spread out. By spreading out, they are changing the actin scaffold within the cell. And that is known within other cell types to change the DNA within the cell and cause the cell to change their behavior.
So I think that the really big pointer on immunology of bone healing is a very, very cogent one. So along those lines, can you give us a practical tip? This is not a commercial planner. With what you know, what should we tell patients who are on anti-inflammatories? We talked about that before in some of the cases, like Dr. Elias's case. How long should they be off anti-inflammatories before? How long should they stay off anti-inflammatories afterwards to not retard that initial inflammation phase?
Yeah, so I'm obviously not a medic, so I will give you my opinion though. There's a really useful cross-disciplinary review of the use of NSAID around spinal fusion surgery. It was published in the European Spine Journal 3 years ago. And what it did was it looked at the effects of NSAID in benchtop testing, in animal testing, and in clinical tests, both in spinal indications and other orthopedic indications. And what they discovered is indeed there is a type, dose, and duration effect of anti-inflammatory drugs on spine fusion outcomes. Essentially, if you suppress the immune system too much, there's a good chance you're going to impair the body's ability to cause a fusion. That's as much as we know from the research. I think it's a really opportune time for people to look into the effects of these concomitant therapies and the effect that they have on fusion outcomes.
So having some inflammation is good, too much is bad. Too much sustained inflammation will retard bone healing, lead to fibroblast differentiation. Is that a fair summary?
That is a fair summary, yeah, that's a great summary.
Well, really well done, and I think we'll get a lot of viewers on this great presentation, and our fellows will disseminate that. So thank you so much for joining us on Utrecht, and we look forward to future interactions.
Thank you very much for the invitation to talk. Appreciate it.
Take care. Bye-bye.
Bye-bye.
Thanks for coming, guys.